Hi, this is Professor O'Connor again for Part 3 of Acute Respiratory Disorders in Children. This part will focus on the specific diagnosis of tonsillitis. Tonsillitis is caused by a virus or a bacteria, and as a result, the tonsils become inflamed because of that infection, and they hypertrophy. And the picture that I have here is a hypertrophy of the palatine tonsils. The diagnostic procedures used is to visualize the palatine tonsils, which will appear large and inflamed. Sometimes they can actually be so inflamed that they're touching, and that is called kissing tonsils. We also get a throat culture, and adenoids need radiologic studies because they sit right on top of the palatine tonsils. The signs and symptoms are frequent throat infections, breathing and swallowing difficulties. They have enlarged cervical lymph nodes. They tend to be mouth breathers, and they have dry, irritated mucous membranes. If they have adenoiditis, they will have nasal stuffiness, nasal discharge, postnasal drip, and coughing, and excessive throat clearing. This is a photograph that I got off of the internet, and it's from a government website, and it's showing tonsillitis. You can see that the right palatine tonsil is very, very inflamed, and there's a lot of white exudate. So this is probably bacterial in origin. There's also a YouTube clip that I will be posting after the video so that you can access that. Medical treatment is generally symptomatic. We give acetaminophen for pain and fever, antibiotics if it has been diagnosed as bacterial. We offer cool, non-acid, soft foods, ice chips, and frozen juice pops. Surgical treatment is considered with recurrent infections, and that would be defined as 3 per year for 3 successive years. And the other times would be chronic tonsillitis, where it's occurring all the time, frequently, obstructive sleep apnea, malformations that cause sleep disorders, facial growth or abnormality. And we tend not to do tonsillectomies in children who are under 3 years of age. We try to postpone it as long as possible, because if it is performed in a child under 3 years of age, it is possible for the tonsils to grow back, and the problem would then continue. So for nursing assessment, as a nurse, think like a nurse, you need to assess for fever, currently or by history, assess for history of pharyngitis, sore throats, or tonsillitis, and assess for hoarseness or a muffled voice. We want to inspect the pharynx for redness or enlargement of the tonsils, assess for difficulty of breathing or swallowing, and assess for tonsils that are so swollen that they touch at midline, noted as the kissing tonsils. The airway may become obstructed. The inflamed adenoids can cause obstructed posterior nares. They tend to be mouth breathers or snorers. You can palpate the cervical nodes for tenderness and enlargement, and perform a rapid strep test or for positive strep group A. For nursing management, preoperatively, there has to be no signs and symptoms of tonsillitis, because it is a very bloody procedure, and if there is an infection, then that allows the opportunistic bacteria to have a free access to the bloodstream and cause major sepsis. We also want to make sure that the clotting studies are normal, so we need to be sure that the PT, PTT, and platelets are normal, and that's usually done prior to the surgery. Postoperatively, one of our goals is to promote airway clearance. So until the child is fully awake, they need to be in side-lying or prone position. Once they're fully awake, they can sit up and elevate the head of the bed, and we suction only if it's absolutely necessary. We do not really want to put anything into the throat and cause possible bleeding. There may be dried blood on the teeth, nares, and in vomit. We want to maintain fluid volume, so we are going to encourage fluid intake, offering cool or cold clear liquids, no milk products until 48 hours after surgery. Citrus, brown, or red fluids should be avoided. You need to calculate the 24-hour fluid volume, and the child needs to drink between 1/3 and 1/2 of the daily fluid requirement before they can be discharged. We want to monitor for postoperative bleeding. Hemorrhage can occur immediately postoperative and up to 10 days after surgery. Inspect the throat for bleeding. Mucus-tinged secretions with blood can be expected. Fresh blood in secretions indicates bleeding. Continuous swallowing or frequent clearing of the throat can indicate bleeding. And other signs of bleeding, such as tachycardia, pallor, restlessness, emesis of bright red blood. We want to relieve pain. So we administer acetaminophen or Tylenol, and it's 10 to 15 milligrams per kilogram per dose every 6 hours, and that should be administered around the clock. Tylenol with codeine is no longer recommended because the codeine can be absorbed at unknown times, and you could be offering it every 6 hours, and maybe it all gets absorbed at 48 hours. We can use an ice collar. We want to prevent trauma to the surgical site, so discourage the child from coughing, clearing their throat, blowing their nose, and using straws. And again, I'm going to emphasize no straws. For home care, we need to teach the parent to report any sign of bleeding to the healthcare practitioner, that the child should be drinking plenty of cool liquids, no milk products until after 48 hours postoperatively, and acetaminophen or Tylenol should be administered every 6 hours around the clock. If they want, they could possibly use an ice collar around the neck, and absolutely no suctioning in the back of the throat, and no straws. This is the end of part 3. Please review the video clips that I have posted underneath this, and then proceed on to part 4.